welcome everybody to our webinar, Voices from the Frontline, Combating the Overdose Crisis. I'm excited to have you all here today. So throughout the course of the evening, we're going to be examining the evolution of drug use and drug policies and the medical landscape, analyzing harmful drug policies across the US, and highlighting the future of the Public Health is Public Safety campaign that we'll be launching. So this topic is extremely important, and the scope of the problem is massive, and it impacts all of us. As we continue this series, we want to share facts, data, and stories. So let's all start off with some heartbreaking data that shows the immensity of this issue. So it's quiz time, and if you would drop your answer in the chat, we want to know how many people in 2023 do you think died of a fatal overdose in America? Oh, use the poll, not the chat. Sorry, y'all.
Wait for a few more folks. It looks like we have all the poll questions actually, so there might be some spoilers for later on, but that's all right. You'll be better educated from the get-go.
So do we want to?
A few more responses. 60% participation. Wow, there we go. Almost 70.
Whoop,
Let's get 2 more folks. Come on. 1 more. 1 more. Oh, it's all right. Let's end the poll.
All right. So the answer is 108,000 people in America died last year from a fatal overdose. And that's disheartening news. But let's get into how we can change the statistics and talk with some people who are doing vital work in their communities. So I'd like to introduce you all to Dr. Cooke, who's a physician and an author, and I will let Dr. Cooke take it away. If you'd introduce yourself and tell us a little about your work and or life experience that ties into drug use and drug policy in the US, that'd be great.
Yeah, thank you so much. And thanks everybody for coming tonight. Looking forward to hearing from people and hopefully having an interesting conversation with some questions and answers. And I hope to learn from you guys as much as, explain what we've been doing in Indiana. So yeah, my name's Dr. William Cooke, born and raised in Indiana. My family actually migrated out of Appalachia, and my grandfather, he only had a 3rd grade education, worked on and off, a lot of generational trauma in my family, and decided to go to medical school to try to help people gain access to a better life that a lot of my family never had access to. And the short answer to your question about, telling everybody about myself and my work is to read my book. It's Canary in the Coal Mine. It's available at Amazon and anywhere else. I do encourage you to read it. The audio version of it's wonderful. The guy who recorded that does a great job of making me sound smart, which I appreciate. So I set up my own practice in 2004 in a small town called Austin, Indiana. They hadn't had a stable physician in the town for about 30 years. There's a couple of doctors that came in and out, but no one that stuck around for any extended period of time. And I was immediately overwhelmed by the number of people coming in requesting controlled medications, large amounts of opioids combined with, benzos and muscle relaxers. And I really didn't feel prepared to face anything like that. And, this continued for years, and just reaching out for resources and just trying to figure out how to combat this overwhelming issue that I was seeing just flooding into my office. And what we know now is that the pharmaceutical companies targeted Appalachia in particular, and targeted primary care providers to prescribe long-acting opioid medications, which at the time we were told was very unlikely to cause addiction. That we were told it was much less than 1% of the population. And that all stems back to this 5-sentence letter that was published in the New England Journal of Medicine in 1980. It wasn't a study, wasn't peer reviewed. It was just a 5-sentence letter. And yet that 5-sentence letter was referenced through the decades over and over and over again as evidence that addiction was rare in patients prescribed opioid medications. And through time, we unfortunately got duped, and a lot of patients, a lot of people got hooked on prescription opioid medications. That continued to escalate and balloon, and overdose deaths escalated. They surpassed accidental deaths from firearms, from motor vehicle accidents. They continued to climb. It started to be recognized as a public health crisis, and a lot of education started coming our way. And we started having studies that showed that no, that wasn't true, that addiction isn't rare, that there are people who, for a variety of reasons, are at risk for substance use disorder if they're prescribed for a period of time opioid medications, or they have gained access to that. What we know is that there's genetic components, and there's also environmental components with adverse childhood experiences and toxic stress in someone's life, and losing someone's sense of purpose and meaning, and that dopamine reward system that's put in place in our brains to keep us going back to the people, places, and things that are safe, that meet our needs, gets hijacked by a pill, by an opioid instead. And so physicians started realizing this around 2012, 2010, 2012. And from that point forward, started prescribing fewer and fewer opioids over the years. But what we see is, unfortunately, suicide deaths started to climb and overdose deaths continued. And so, really looking at what happened across America, what we know is that there's a lot of people dealing with chronic suffering in their lives from a lot of different reasons, whether that's chronic pain, emotional, again, losing their sense of purpose and meaning, growing up in toxic environments, adverse childhood experiences. And instead of the medical community connecting with these people in a meaningful way on a human level and connecting them to resources, the medical community at large put up our hands and walked away. And that left people with no other choice but to turn to other means to obtain the opioid that they were dependent on at that point. That leads to a lot of harms in the community. And we experienced one of the more dramatic harms in Scott County, Indiana, when we became ground zero of the worst drug-fueled HIV outbreak in US history. So the opioid crisis has led into other public health crises of suicides, overdoses, hepatitis C, and HIV spread. And there's a lot of great solutions that have come out of that, but that's what I've seen from a physician standpoint over the years. We have made some progress, and in fact, in 2018, 2019, the overdose deaths actually declined for the first time in several decades. But then we all know what happened in 2020 and 2021 with the pandemic, and they ballooned again, going from around 90,000 to over 100,000, and they've stayed above that level since then. So we're still right in the middle of one of the worst public health crises in the history of our country, of our world. And that's sitting alongside this other crisis of the pandemic that we're still kind of wrestling with. So it's made it complicated, but that's where I've seen things over the last few years with as a physician. I'll turn it back to Lauren to continue.
Thank you for that.
Yeah.
Well, so next I'm going to hand it over to the fabulous John B in just a moment. John Bowman, our campaign organizer in Kentucky. So if you'd like to tell us a little about you and your role and how this has impacted you, and tell us why you got involved in advocacy.
Yes, ma'am. So my name is John Bowman. I live in far eastern Kentucky in Louisa. I'm originally from Georgetown, Kentucky. I'm a person in long-term recovery. I'm also a person who is justice system impacted. Whew, I got a long history. We could go through it. We could be here all day, but I'll give you guys a short version of it. So I first started experimenting with drugs when I was at the age of 13. I was an addict for 24 years. And in that time, I racked up a nice criminal record due to my addiction, to my substance use. And my addiction took me deeper and darker than I ever thought it would. I'm also a person who has used harm reduction services. And today I'm going on 6 years in recovery. And I'm grateful for all of those years. And I'm grateful for all the pain and suffering that I went through in 24 years of active addiction. And in that time, I've lost more friends and family members than I can count on my hands and feet. So this is a issue that is very close to me, very close to my heart. And today I am the Kentucky Senior Campaign Organizer at dream.org. And I get to work on reforming drug policy, working with, community partners across the state to really try to make a lasting and successful impact. Unlike the failed war on drugs that has been going on for 50 years, and if incarceration was the answer to substance use, to addiction, we would have got our way out of that a long time ago. Especially here in Kentucky, where per capita we incarcerate more people than most places on the planet. If Kentucky was a country, it would be number 7 in the world in incarceration. So, and we're not that big. We're only a state of a little over 4 million people. So that says a lot. So personally, I was an IV drug user for a long time. I've had a lot of friends that's been diagnosed with hepatitis C. Luckily for me, I didn't end up getting that, but that was just pure luck. It was nothing to do on my end, because I was going down every path to get to contract hep C and other infectious diseases, because I didn't care about my health. I was more interested on my next fix. And how I got involved in this work is, I love to help people. Once I got into recovery, it was something that felt right. It felt great. And it was just a natural progression from the work that I was doing, working in the addiction field, in the treatment field. And here in Kentucky, the thing is, we have, more treatment beds per capita than any other state, but we have a problem there because we have a lack of access to those beds. And that's a real issue in this state. We're a very rural state. We lack a lot of harm reduction resources across the state. And they're very vital for us moving forward. And with the advocacy part of it, getting to work on reforming the drug policies that have impacted my life is something that it brings me a lot of pride and a lot of joy. I get to work with folks like the amazing Dr. Cooke here, who's on this call, and all my wonderful folks at Dream. And there's a lot of people on this call I get to work with across the great state of Kentucky. And it's definitely something that when you're in active addiction and when you're battling with substance use, when you're battling with mental health, you never think you would see yourself in these roles. But it just goes to show that this is possible, and we need those resources because there's people like me all across the country that, given the chance, that they can do great things. But without having those resources in place and without, accessibility to those resources, we're losing countless individuals daily, for no reason. These are preventable deaths, and we have to stop looking at addiction as a moral failing, as a criminal issue. It is a health issue. It really is, so that's the way that we have to frame this going forward. We have to frame it as a health issue. We have to frame it as a disease. This is not because, I'm a bad person. No, I'm a person. I just made some horrible decisions. My decision-making skills were not that good. And once you get deep into addiction, you don't have rational thinking. I didn't care about my health. I didn't care about myself or anyone else. And to think that, someone incarcerating me is going to change that, that's just not feasible. The only thing that incarceration did was make me want to use more when I got out. That's a whole nother trauma. It's not for the faint of heart, I'll tell you that. And that is where we see one of our highest rates of overdoses upon release from incarceration, because we're not doing anything to treat addiction while someone is incarcerated. We're just locking them up. When they get out, they're going right back to what they know, and it's killing them. And this is a matter of life or death. This isn't something to play with. Things are so much different now from the last time that I used drugs. It's not the same, and I use a lot of hard substances, and it's a miracle that I'm not a statistic. We'll put it that way. But in saying that, I'm grateful that I'm not still in that madness today because of this crazy, unsafe supply that, fentanyl's in pretty much every drug that you see today. And I really didn't have to deal with that. And I'm grateful for that, because a lot of folks are dying on things that they think is a different drug, and it's really not. So, there is ways we can combat this, but it's going to take all of us. This is not something that one person, one group, one organization is going to be able to tackle alone. This is going to take communities to get involved in this. This is going to take all of us from every walk of life. And the thing about addiction, it doesn't discriminate. It doesn't care if you're white, black, if you vote red, you vote blue. It doesn't matter if you're in the rural area of a state, if you're in the urban area of the state, it does not matter. And the thing about this is, if it hasn't touched you directly, I'm pretty sure it's touched you indirectly. If it hasn't been a member of your family, it's touched a member of a family friend or someone that this is something that we have to look at it from every aspect. And it's going to take every person to really get behind this. I work with folks all over the state in all different aspects. I work with people in law enforcement, with the business community, the faith community, harm reduction specialists, addiction specialists, judges, attorney, whatever it may be, because it takes all of us. It takes all of us to fight this and to do it correctly. And with that, I will turn it back over to the amazing Miss Lauren.
The only thing that I would add
Sorry, go ahead.
the only thing I would add to what John just said is that there's also not one policy solution, right? Like, there are lots of solutions that exist, and it's going to take more than just one thing. We've got to attack this from a lot of different angles. And I'm sorry, Dr. Cooke, did you mean to say something?
Oh, no, I was just going to piggyback off of a couple of things that John said, because I thought they were so spot on. One, this is not a moral failing. There are so many people who are prescribed opioid pain medications every day, and they do just fine, and then others don't. There's something there that we can acknowledge is a trigger, whether that's, again, genetic or something that happened to them growing up. whatever that may be. It is a disease. We've documented this over and over again through the decades. We need to get past this idea that it's a moral failing. Obviously, we need law enforcement's assistance in this situation. There are behaviors that we just don't want to have happening in our communities, and we need to acknowledge that part of this. And unfortunately, some behaviors are associated with substance use disorder, but substance use disorder is not causing those behaviors. So we need to break that. I've seen children be taken away from parents because they tested positive for a substance when they're great parents. And that child is now traumatized because they were removed from a home where they were safe, well cared for. The parents were going to work, they were maintaining their home, they were taking care of their children. Nothing was wrong there. Yet they took the kids away because we've stigmatized substance use so much that is a moral failing, and that parent has lost their right to the child, or maybe a random stop, and all of a sudden they're in jail. And they had a job and they were doing well, and their whole family is now traumatized. Their children is traumatized. Their employer is harmed because this person is now in jail. We need to get past the idea that substance use alone is a moral failing and deserves to be punished by incarceration. The behaviors, yes, if somebody's sticking people up at gunpoint, robbing people, whatever, we need to do something about that. And law enforcement needs to be a part of that. We can dissect out issues. We're capable of doing that. And then connecting people to treatment when there is a substance use disorder there, and stop just working on punishing it. Because again, if it was going to fix the problem, it would have long ago. And the only thing that happens, and John said this perfectly, when you put someone in jail who is, addicted to a pain medication or heroin or fentanyl or whatever, they go through horrible withdrawal. They lose their tolerance. When they're released from jail, they're at an incredible increased risk of dying. And the only thing that's doing is causing people to die. And that's not what we do this for. We don't have law enforcement in our community to increase the risk of death. That is not something that they would be proud of, or we should be proud of as a community. And so if that is the truth, and we know it's the truth because we have studies that show it and prove it, then something needs to change. And some jails are doing it and some are not. And the last thing that I was going to say, I forgot. So we'll just move on. It'll come back to me.
Well, it'll come back to you in a minute. All right. On that note, we're going to go to our next quiz question, which everybody should have already answered. If you didn't answer your quiz questions a moment ago, there's probably an opportunity popping up for you right now. But the question is, of the estimated 43.7 million people that need treatment for substance use disorder in 2021, only 6.8% received treatment at a specialty substance use disorder treatment facility, and only 4.1 million, which is 9.4%, received any treatment at all, such as Alcoholics Anonymous, Narcotics Anonymous, or Smart Recovery. So, out of the people needing treatment for a substance use disorder in 2021, what percentage actually received treatment? And how many of y'all got that right? Just kind of before we move on to the next piece, I just want to ad lib for a second and say that I remember a moment in my life when I knew that I needed help and didn't know what that looked like, and reached out to a hotline and begged for help. I mean, I knew it was pretty desperate, and they said, "Oh, we're going to put you on a 6-week waiting list." And I remember thinking that I was going to be dead in 6 weeks. And so this conversation about, having beds, but not having accessible beds, like when a person is actually ready and reaching out and asking for that assistance, we need to be ready to receive them in that moment so that they can get the help that they need. So, question for both of you. You alluded to issues that you saw in your community to include overdose, HIV outbreaks, lack of harm reduction services, incarceration and stigma, to name a few. But can you tell us how systemic policy plays into some of these issues? And how do you think those policies help or harm our communities? I'll hand it to you, John, to kick us off.
All right. So for me personally, the majority of the policies that are in place have been harmful for me personally, especially with my substance use, and just growing up with the color of my skin. So, you know, that's one of the aspects, but there are good policies in place as well. Here in Kentucky last year, we worked on a fentanyl test strip bill to legalize fentanyl test strips. Why they were considered paraphernalia, I don't know, but you know, I think that is vital for people to be able to do drug checking. You know, just because someone has a test strip on them, that doesn't mean that they're, you know, actively seeking fentanyl. It could be that, you know, they are trying to make sure that's not in their drug of choice. You know, and with different harm reduction policies, here in Kentucky, we have syringe service programs, but they're only operated at local health departments, and not every health department has one. And they're also during regular business hours. I don't know what addicts that these people researched before they made this policy, but when I was using, I didn't use banker's hours. My hours were usually when mid-afternoon till early morning was the hours that I operated. And that's one of the things we need to look at. You know, if we're providing these services, how can we reach the most people? You know, how can we make these policies where it is actually helping the most people and not just looking good on paper? And those are some of the policies that we can work on. You know, there's a lot of work that still needs to be done. There's been a lot of good work over the past, you know, 5-6 years, but there's so much more that we can do. And that's just not here in this state, that's across the country. You know, this is not just a Kentucky issue. This is not just a white or black issue. Again, this is a everyone issue. And you know, it takes everyone like giving feedback on what they see in their neighborhoods and what works. And really one of the best things that I've seen is really meeting people where they're at, and without judgment, you know, and really offering them those services, and being there and supporting them and showing them the love that they might not have seen for years on end, and just being consistent. That consistency is a big part. Just continually, if you do outreach, you know, just going out every day and just meeting people where they're at without judgment. They might not be ready for treatment services at that time, but when they are there, they're going to know who they can turn to. They're going to know, you know, who they can call. And like Lauren alluded to earlier, you know, when those people are ready for treatment, they're ready for treatment. If, you know, there's a delay there, they might be like, well, the hell with this. I'm not doing this. You know, I was ready, but now I don't want to go. I've been there before. You know, it took me multiple trips to treatment. I got sent by a parole officer once. I wasn't ready, didn't want it, didn't work. The last time I went, I was ready for treatment. You know, I got court ordered, but by that time I was ready to stop. I just didn't know how. And it took 24 years to actually get to that point. And a judge and a prosecutor looked at my record, was like, Mr. Bowman, everything on here is drug and alcohol related. Instead of sending you to jail, if you want to do 30 days in jail, you can, but we would rather see you go to treatment for 30 days. And by that time I wanted to stop. So that's one of the things that really helped me was, you know, getting that opportunity to go. You know, and I think that's a good thing. I think, you know, us actually finding those barriers to treatment and knocking those down. And I think that is a policy issue. You know, I think that is some things that we can come together on a national level and really, you know, knock those barriers to treatment down, and really make sure that people are getting access to treatment when needed. Not just when we think they need it, but when they are ready for it. I've seen a lot of people get forced into treatment, and it doesn't always work. But when they're ready, the majority of the time it does work, because they know they need something different. And that's the way it was for me, at least. I can't speak for everyone, but I can speak for myself. But I really think it's, learning what policies are in your areas, and really seeing what's lacking, and if there's good policies, how can we build on those? There's certain things that we could continue to build upon. And, in the policy world, when you're working in the policy world, if something doesn't go right immediately, don't give up. If you can get your foot in the door and get people talking about it, hey, you got a starting spot. And that's all we really need, is a place to start, and we can continue to build off that. And really, again, it's, what is needed in your local area, because all areas are different, but we all have the same issues and the same problems, but policy wise, all areas are different. So just really, my advice to folks would be to really see what policies that your area has in place, what policies are lacking, and what the needs of those individuals in those communities are. Because we all have basic needs that need to be met. And, harm reduction gets a bad rap sometimes, but I'm going to say it like this. This is something that me and a couple of my friends were talking about. And for me, harm reduction is basic human necessities. A lot of people hear it and they think just syringe service programs or medically assisted treatment, but it's so much more than that. It's also transportation, it's housing, it's food, childcare. It's really basic human necessities. And how can we make sure that the people in our communities that need those services are getting those services? And with that, I will hand it back over to Lauren.
Well, I'll add a couple of things to that before I pass it back to Dr. Cooke. I think the thing that I tell people all the time about harm reduction is parenting is harm reduction. That's like, if you have teenagers, you may know what I'm talking about. Like, it's deciding what is the least harmful way that you can parent this child, what is the best possible outcome, and picking your battles. That's what harm reduction is. Policy work is harm reduction. Like, it's not just a syringe exchange and services like that. So just a different kind of frame to think about harm reduction. And then the other thing that I'll add is I think that recovery and treatment services are much more effective when it's something that the person desires. At the same time, I think offering it to people in jail or in lieu of jail is a really strong thing, because even if a person isn't ready, when you learn something, you don't just lose it automatically. And I'll say for myself, recovery and, recovery is an individual pathway, right? People find their own path. It's not cookie cutter. It's not the same for everybody. For me, I was court mandated into a program. It didn't stick because I knew I wasn't done yet. But all of the things that I learned in that program stuck with me. And when I was ready, was later able to apply them. So I think those are the two things that I would pull out from that. But Dr. Cooke, tell us about your experience with harmful policy in Austin and Indiana, any positive changes that you've seen. Tell us about the work that you've done in your spaces.
Yeah, thank you. And John, thank you for the wise words that you shared. And one of the last things you mentioned were basic human and safety needs, and access to transportation. And it goes into so many things. It makes me think how life expectancy in the United States has been declining over the last few years. And now we rank last in the developed world for life expectancy. It's a country that espouses life, liberty, and the pursuit of happiness, and we get the first one wrong. And we're right here in the middle of the Olympics. Looks like we're going to win the medal total for the world, because we value the Olympics to the point where we invest heavily in winning. Yet life somehow we're okay with that coming in last in the developed world. That doesn't really make a lot of sense to me. And when you start looking at this in a global sense across the country, it isn't in every community. We have pockets of communities where life expectancy can be as much as 3 decades shorter. You know, and we talk about the American dream, and the original definition of the American dream was that everyone has equal opportunity regardless of their circumstance at birth. And when you look at zip code, and people born in certain situations have a 3 decade shorter life, we can't say that the American dream is alive and well. I'm mentioning this in the context of our conversation because they're directly related. One of the drivers of the decline in life expectancy is overdose deaths, is suicide deaths. But underlying that is the sense of chronic suffering that leads into so many other early deaths, from cancer to diabetes, heart disease, strokes. The same factors that lead to people overdosing and dying or committing suicide and dying also leads to an increase in cardiometabolic diseases and cancer early deaths in general. Again, this is not a moral failing, it's a disease. Just like cancer is a disease, just like diabetes is a disease, heart disease is a disease, substance use disorder is a disease. These diseases are coming out of chronic suffering that is allowed to continue in our communities, related to what the Surgeon General defined in a report that they published in 2019 thereabouts as vital community factors. Sometimes we also talked about them as social determinants of health. These vital community factors are humane housing, transportation, having your basic human and safety needs met, a sense of community and belonging, lifelong learning. You know, these things are so inherent to what it is to be human. If they're lacking, people die. They die from cancer. They die from diabetes. They die from loneliness. They also die from overdoses related to substance use disorder. So as a physician, I like to take a step back and not say, you know, this is unique to people living with substance use disorder and dying of substance use disorder. This is a community harm. And how do we reduce the harm that's occurring in our community in general? We do exactly what John said. We start connecting to people on a human level. You may remember Maslow's hierarchy of needs. On the bottom are our basic human and safety needs. And what Maslow said is that if someone appears to not be trying, to not be doing well in their life, it's probably not because they don't want to do better. Who doesn't want to do better? It's probably because their lower needs are going unmet. So if we want to save lives, the first thing we can do is get down to those basic human and safety needs, a sense of belonging, a sense of community, access to transportation. A lot of my patients walk to my clinic. And we say, well, you need to go down to the hospital for a study. They can't get there unless somebody drives them down there because it's too far away. Just picking up medications sometimes is difficult for people. So, you know, we get all over people for not being compliant with their diabetes, but they can't literally get to the pharmacy to be compliant. It's not their fault. It's our community's fault for allowing them to not have that need met in their life. So harm reduction, yeah, it's this big topic that we are failing people at on a fundamental level. And I'm just going to say it out loud. It's a cultural divide that we have in America where there's half of the country who really believes in a social responsibility to every child born in our community, and this overemphasis on individual choice and allowing people to experience the consequences of their choices, without stopping to think of, well, people can only make choices from options available to them, right? If you don't have the option to access transportation in your community, how can we hold that person accountable and allow them to experience the consequences of that choice? We need to make sure that healthy choices are available to every single child, every single person, and every single community. When we look at substance use disorder in general, to reduce the risk of overdosing and dying, we have to make fentanyl test strips available to people. To label it as a paraphernalia so that we can arrest more people doesn't make sense, because we're killing people in the process of doing that. Fentanyl in general, the reason we have these higher and higher strength opioids coming into our communities, goes right back to abolition. During abolition, we had bootleggers, right? We didn't have barrel rollers. We had bootleggers. They smuggled highly concentrated alcohol and then diluted it to distribute. They didn't produce these normal concentration of alcohol in these large barrels. It was literally concentrated so much that they could carry it in a boot to smuggle it. In order to smuggle a substance, it has to be highly concentrated. And so these very punitive laws just encourage these higher strength substances to come into our community, which is literally killing people. To reduce the risk of contracting a communicable disease that is harming our communities from a financial standpoint, because these hepatitis C and HIV are very expensive to treat, as well as killing people. We have to be willing to protect people who are injecting drugs. Just telling people to not do it isn't going to do a damn thing. Sure, we don't want people injecting drugs, but until they take the steps to no longer do that, we must protect them. We can't help people who have died. We can't prevent the transmission of HIV after it has already been transmitted. And so it only makes sense as a healthcare provider to prevent these things. We talk about prevention so much in America, but we don't ever get down to how do we implement this on a policy level. We're really, really good in the United States at treating sick people. There's no place in the world better to be than the United States if you're sick. But if you're just trying to be healthy, there's a lot of better places to be that do it better than we do. I'm not okay with that. Again, if we were coming in last in the Olympics, we would move heaven and earth. Congress would be in session 24 hours and there would be a bipartisan effort to make that change, right? Yet, in order to get a syringe service program into a community who is experiencing the worst drug-fueled HIV outbreak in US history, we had to change the law in Indiana. And it did happen, but it happened in a way that was very compromised. And it could only be passed by each county, and the county commissioners were the ones who voted on it, not the healthcare providers or the health department. And so in 2015, Scott County was able to start a syringe service program at the health department. It was very successful. We went from 200 HIV cases quickly down to only one in 2020 and 2021 each. Pretty much got it to where it was controllable. And then the commissioners decided that it had served its purpose and they closed it. And almost immediately we saw 4 new cases the first 6 months of that year that they closed it. Alongside that, we were doing over 1,000 HIV tests in the community a year. So we were doing a lot of surveillance, and we know that linkage to care and early treatment will prevent further spread of HIV in the community. So by testing 1,000 people, we only were finding one a year. All of a sudden, the tests went down to 100 or less, and yet we were still finding 4 or more. So we're not even able to screen people who inject drugs for HIV anymore because we lost access. And that access was so incredibly important in our community. It was one of the doors to recovery because alongside syringe service programs are healthcare workers and people who are certified peer specialists who can help walk somebody through the steps of recovery. And we had so many people enter in recovery through the syringe service program. And then when those doors close, where does someone go for help? I said it before, I'll say it again. People can only make choices from options available to them. When we remove an access point to people in need and they no longer have that choice, whose fault is that? It's not theirs, right? And so these policies matter, and we can speak of them in a humanistic way. And I always like to even introduce people who are making these policy decisions to people who have accessed these harm reduction strategies, like a syringe service program. And they're always impressed. It's funny, they'll be so impressed with somebody that's in the recovery field. And when they find out that they entered into recovery through a syringe service program, all of a sudden, they don't want to hear it any longer. But that's the reality. That's the truth. That person wouldn't be the respected person that they see them as today if they didn't have that choice to enter into recovery, to access help in the first place. And the last thing that I'll say, because I want to make sure that we continue moving on, is we talk a lot about treatment, and that's fine. But to me, substance use disorder is no different than diabetes or heart failure. And I admit patients to the hospital who are experiencing an exacerbation of their diabetes or their heart failure. While they're in the hospital, I'm stabilizing them. I'm not curing them from that disease. That's a lifelong, chronic, relapsing disease that needs chronic, lifelong treatment. We need to, I think, shift the paradigm of what treatment means. And instead of expecting us to open up beds, which we absolutely need for the stabilization portion, invest heavily within our communities so that when people leave jail, prison, a recovery center, what have you, maybe they just go away to visit some family in another state to get away from everything. But when they come back, it's all waiting for them. And the same toxic conditions that existed that led to them turning to a substance still exists there. We talk about people, places, and things. And I mentioned it a while ago that we return to the people and places and things that release the dopamine reward system in our brains. And if we're not meeting that through purpose and meaning in our lives, through meaningful interactions with other people, meaningful work, we're going to seek it somewhere else. And someone with substance use disorder, they've found that release through the old people, places, and things. That's why we talk about those so much. And so we need to invest heavily in our communities to put into place where people live what's so successful in the inpatient recovery centers. We know when we surround people with stable housing, because they're safe there. They have their access to food, they have access to community, they have access to a physician, a therapist, recovery support people. They don't have to worry about transportation. If we replicate that in every community, when people go inpatient to stabilize, they can return to a treatment modality that we know works and support them moving forward. So until we do that, I don't think we're ever going to get beyond where where we have people chronically relapsing. It's like allowing somebody with heart failure to just go back home and have no education, no dietitian, no access to pharmacy, no access to a physician who's going to be monitoring their disease and supporting their decisions and helping them do well. We would just have people in and out of the hospital with heart failure. We do anyway, because it's a chronic relapsing condition, just like substance use disorder. So that would be the we want to keep people alive. There's a continuum of care, right? So if people who are still using, still injecting, that we want to keep them alive until, like we've said, they're ready. We need to allow them access to healthy choices so that then when they are ready, they can make that choice, because we can only make choices from options available to them. And we act immediately to stabilize them in an inpatient program or whatever that may look like. And then they need a safe place to return that's going to support them over their lifetime.
Perfect. Whew, that's a lot. Thank you. We're a lot of comments and agreements in the chat. And I will say that, I don't often get the chance to talk about Maslow's hierarchy of needs, but at one point I had been pulled into a local conversation with our sheriff who wanted to build a new women's jail, and she wanted it to be a model facility. And we were doing stakeholder meetings, and a lot of us did not want a new jail built, but if they were going to build one, I wanted input on what it was going to look like. And so I joined these stakeholder conversations, and they would ask us questions, people who had been incarcerated there. And I said, you've got a population of people there right now that we could go and talk to. So she allowed us access into the jail to go do focus groups. We had 3 different groups of women, and we went in, and when we started the focus groups, they asked us, what does a model facility look like? And they said, dream big, there's no limitations here. What does it look like? And my hand shot up and I said, it's got a swimming pool and a movie theater. And I know that we're not getting a jail with a swimming pool and a movie theater, but you told me to dream big, and I know how to dream big these days. And we went into these focus groups, and I did the same thing with the women. And I said, what does a model facility look like? What's different for you in a new building? And every group of women, all separate, started with their most basic needs. If somebody said, if I could work for deodorant, somebody else said, fresh fruits and vegetables. If we could get a bra, real underwear before 3 months in, right? Like most basic needs. And then once we would get in each group, it always started the same: basic needs, basic needs, basic needs. And in the next question was, okay, what else? Dream big. And as soon as you got past their basic needs, they hit a mental wall, and you could see it in their head. And then they'd be like, oh, we're not supposed to like it here. This is supposed to make us not want to come back. And I was like, how's that working for you? Because if ultimately it's not, a lot of those women had been in and out, and it wasn't enjoyable. But what I left there really thinking about was how, when you're so focused on surviving from one day to the next, you don't have the mental capacity to transform your life the way we have an expectation of people who are reentering our community from jails or recovery centers or rehabs or any of these other spaces. If somebody in addiction is just focused on getting through the end of the day and surviving, they don't have the ability to think about how to transform their lives. And I think that's where harm reduction creates space for people to be able to start having that space in their minds about what change can look like. So thanks for coming to my TED Talk, and thanks for opening up the Maslow's hierarchy of needs for me to go into that. Harrison, give us the next quiz question.
Got it. There it is on the screen. I'll have it
Nope,
pop
that's
up.
not it.
That's
not?
that's
It
the
is
running
it,
show.
but it's not the slide. The
Sorry.
question is, how much money will Kentucky dedicate towards funding incarceration in the next year, fiscal year 2025? And remember, Kentucky's not a big state. It's not Texas where I'm at. So what do y'all think Kentucky is willing to fork over to incarcerate And remember what we said about 15% of people getting substance use treatment. And the answer is, drum roll, please, $805 million. Or is that a billion? That's a billion. $805 billion.
No, million.
Is it million? Okay. Whew.
Yeah.
All right. Adjust my glasses. So, yep, you read that right. Oh, yay. Thanks for alliterating it. $805 million in a place where less than 15% of people can access treatment services. That doesn't feel right. So, question, you've both done amazing work in your communities and on these issues. And so I'd love to hear if you could tell us a little more about that specific work that you've done in your communities. And Dr. Cooke, I know you touched on this a little bit in your previous question, but we're going to start with you and then have you pass it to John to finish.
Okay, thank you. Yeah. So as a family physician, it was a little uncomfortable, I guess, because we really didn't get any significant training. The most memorable interaction I had during my training when it came to substance use disorder was I had several professors, physicians, basically tell us that, if somebody is using drugs, they're really not worth working with. Yeah. And what they meant by that was they felt that they would take up so much of our time and resources that we wouldn't be able to spend the time that we needed to with the patients that mattered, which is just a terrible thing to say. And in my early years, I took that into my practice. I remember this young woman who came to me for help, and she had gone to a surgeon and was getting pain pills from the surgeon, and it was a long way for her, and wanted me to work with her, and I agreed to work with her. We talked about how she would go to physical therapy, and our goal would be to get her off of them. She was only in her 30s. Had this contract that I was given to during my training that outlined her responsibilities. We got a drug screen and records, and everything checked out. She was only taking the pain medication, and so we started working together. And over several months, she was going to her therapist visits, and things were going well. And then, at some point down the road, she came in for a random drug screen, and other substances were in her urine. And I followed my training. I took out the form letter that one of my preceptors had given me that said that you broke your contract and we're no longer able to care for you. Please find another doctor. Put her name in it, signed it, sent it in the mail. I'm embarrassed to say that's what I did. She came in a few days later, ripped up the letter, threw it in my receptionist's face, started yelling and screaming. Dr. Cooke cut me off. What am I supposed to do? Tore things off the wall. We had to call the police because she was just, the behavior part of things were just out of control. They came and was taking her away. And I remembered my Aunt Sally, who was in her 30s when she actually died of a drug overdose after having been arrested and go into inpatient programs over and over again. And eventually she died of a drug overdose. And I was worried about this young woman, and I asked what help would be there for her. And the officer just, shrugged and walked away. And, looking into things, at the time, there really wasn't a lot there. So it really kind of motivated me to look into things more. And long story short, through my journey, I connected with some addictionologists, did a lot of research, and started understanding that this is a disease, not a moral failing. And eventually, became board certified in addiction medicine, a fellow of ASAM now. And, I look back on that and just can't believe I did that. Interestingly, I met the same young woman in the emergency department goodness, years and years later, she'd come in for abdominal pain, and I walked in the room and I recognized her. She recognized me. It was a really weird interaction. But I sat down and reassured her that I would help her. And I started doing a workup. And the guy with her gave me this letter that she had been carrying around with her for, he said, for a few months, maybe a year. And it was addressed to me. And he said she was just afraid to mail it for some reason. And it describes how, she grew up in a very poor home where there was substances used, and she never felt like she belonged and was cared for. And when she was around 13, she went to a dentist and was prescribed a pain pill. And she didn't know what it was, but she said in her letter, she said, it made me feel okay for the first time in my life. And so, of course, a 13-year-old feeling okay for the first time in their life, they would continue to seek that. It wasn't until, 18 or 19, she started realizing what she was doing. And by then she was already, addicted to this, and would do just about anything to feel okay and to get that. And this continued for a while. And then she came to me. In the letter, she said, you found out that I was using other things, and I don't blame you for kicking me out. I just want help. I don't want drugs. Will you help me? And as I said, I was embarrassed that I treated people this way. And I felt this weight lift off my shoulders that I had this other chance. And then I pulled up her CT result, and it said metastatic cervical cancer. And metastatic cervical cancer shouldn't happen, because with screening and access to preventative services, no woman should ever die of cervical cancer. And I had personally cut her off from the preventative services that she could have accessed. And so, these policies, these decisions, these ways that we punish people, again, they harm people, they kill people. And we need to get away from that. And that's what I've learned very, firsthand, is that these are human lives. These are mothers, these are brothers, they're fathers. They're valuable members of our community. And to be able to connect with them on a human level is what, we just have to get to being willing to do. I think I saw in the comments asking if an addictionologist is a thing. It's what it's commonly called. It's addiction medicine is the actual board certification. And there's a couple routes to it. You can go to a fellowship, and that's the only way to get to it now. But a few years back, when they were really trying to get people to be involved in this, life experiences and practice experiences would matter, and you would be able to sit for that. But I got a kick out of that comment, so I appreciate it. I'll pass it over to John to comment on things, and we'll keep moving.
Thank you, Dr. Cooke. Oh, so the work that I've been doing here in Kentucky, it really started when I got into recovery and really wanting to help people find a new way of life. And now I get to, in the past year and a half, I've been doing a tour of the state of Kentucky, a public health is public safety tour. We've hosted 9 events across the state so far. We have 1 more to go this year. And with those, we bring together community members, directly impacted Kentuckians, the business community, the faith community, harm reduction specialists, mental health specialists, addiction specialists, law enforcement, youth advocates, and really try to find solutions, meaningful solutions to these issues. We have some really amazing discussions, and it's a safe space where people can be themselves and, really ask some tough questions when it comes to that part. We have a couple panels, and then we do some focus groups in the middle and find out what issues are the most important to the people in those communities. And last year when we done this, the biggest one was youth prevention. How can we keep our youth from going down the paths of addiction and incarceration? So I added that into the events this year. And that has been one of the biggest pieces that I've got really positive feedback on was youth prevention, because I brought actual youth into these events. And hearing from the youth, kids 17 to I think 24 so far is what's been at these events, and actually hearing what they think and how they think prevention will, what prevention tactics will work with them and what strategies will work with them. And hearing it from that youth perspective and not an adult telling them, no, this is what is going to work for you. Really hearing from them what will work for them has been amazing. And just really making that safe space for them to be able to open up like that has been amazing. And also getting to speak at different events. I get invited to speak a lot because of my recovery journey and the work that I do across the state. And I get to work with amazing partners across the state. Nothing I do would be nowhere near as successful as it is without the amazing people that I get to work with. And I'm grateful for those relationships. Some of them are on the call. Some of them didn't get to make it. They had, other commitments, but I'm grateful for those people because they include me. They don't judge me for my past. Some of them have a past just like mine. Some of them don't, but they include me in those conversations. And I think that's one of the things that we have to focus on going forward is we have to include, the people who use drugs, the people who use harm reduction services, the people, in recovery, and and especially folks in recovery, we have to stop judging how other people recover. Again, that is not a blanket thing. Recovery is not a blanket thing. It's individualized because everyone is different. Just because we traveled similar paths and we didn't take the same road to get there, we all had different life experiences. We got to these destinations on different routes. They might have been pretty close together, but we weren't walking hand in hand through them. So, we have to make sure that we individualize recovery, we individualize harm reduction, and we treat people as people. That's the main thing. We have to treat people as people. They're not statistics. They're our neighbors. They're someone's father, mother, son, daughter, brother, sister, aunt, uncle, cousin, friend. But they're everyone's neighbor. You know, and for me, that is a big one. For me, I was always told, to love my neighbor as myself, and that's what I try to do. And that's one of the things that all the people that I work with across the state, across the country, that's what they do. They look out for the people that no one else looks out for. I don't care what you believe in or what you do, but if you're willing to work with me to help someone change their life for the better, I'm willing to work with you. And I think that's the mindset that we have to have as a country going forward. What does this person need and how can I help them? Not what can they do for me? What can I do for them? And that is the biggest blessing that I get today is that I get to ask people, how can I help you? What can I do for you? And I'm not wanting anything in return. I just, how can I help you? What do you need from me? And if I can't help you with something, I'm sure that I know somebody that can, and that's the amazing thing about the people that I work with. They're always willing to help. No matter if they're on this side of the state or all the way over on the Arkansas border on that side of the state. But they're always willing to help, and they're always just a phone call away. And that's one of my favorite things about Kentucky is everyone willing to work together. Everyone that does this work that I've had the pleasure of working with is they're amazing to work with and they love working with each other. And we're trying to break down stigma. We're trying to break down silos. We're trying to make sure that we can help our communities. And again, it's going to take everyone to do this. And it doesn't matter what community you live in, We all have the same issues, the same problems. So, just finding ways to work together. And that's what I'm going to continue to do here in the state. That's, that's one of the main things I love about Dream is, it doesn't matter what you believe in or where you are. If you're willing to work with us, we're willing to work with you. And, that's the way that we change things is working together, those uncommon allies. I'm someone that has been through the justice system. I have those nice F's on my record, but today I work really closely with some really good law enforcement guys from my hometown, which is still weird to this day. But I never thought that I would be working with those guys, but it's a pleasure because they are really trying to move the needle. They're out there doing good work. They work with folks in recovery. They work with harm reduction specialists, and they're willing to learn from us. That's what makes them special in my eyes. They were willing to learn from people like me because they didn't have a clue about the disease of addiction or, harm reduction techniques, what works and what doesn't. But they were willing to ask questions and they were willing to learn from folks like us and work with us to make that community safer. And that place holds a very near, a very deep place in my heart because that is where I'm from. So working with them has been amazing. And I've took them across the state with me, and they've been at every event that I've done because I want every community to see that, not all law enforcement are bad. Some of them there are here to help, and some are really good and doing really good work. But we have to be willing to have that conversation with them and ask how we can benefit the work that they're doing. How can I work with you to make this a better place? And, when you hear a cop say that incarceration is not the answer to addiction or mental health or substance use, I gravitate towards those people. And, if I'm willing to take that chance, I hope others are too. And I really look forward to the work that we're all going to be doing in the future. And I look forward to working with anyone that wants to work with me on anything to deal with harm reduction or substance use or helping someone better their life. I'm all for it. And I just want to thank you all for being here today. Thanks for listening to me. Thanks for coming to the TED Talk. And I'll pass it back over to Lauren.
We're actually going to pass it over to Jay.
Yeah, so real quickly, I know we have been going for a while. In a second, we will dive a little bit into like some action items and go into a Q&A, but because we have been going on for a while, everyone can go ahead and take a 2-minute break if you need to run to the restroom, if you need to, anything that you need to do, grab a glass of water, move your legs, things like that. Here's the QR code to join our drug policy campaign. And when we come back from those 2 minutes, I'll dive a little bit into what that is and how we'll be reaching out once we get those signups. So 2 minutes and we will be back. All right, so it has been about 2 minutes. I will give like a couple seconds for everybody to get back to their seats. And while we're waiting for people, I'll just do a brief introduction of myself. For those of you who don't know me, my name is Jay Hunt Garcia. I'm the digital community organizer here at dream.org. I'm also a person who uses drugs, and I'm on medication for opioid use disorder, so I'm on methadone. And starting next week, I officially start my hepatitis C treatment. So I'm definitely very impacted by this issue and very excited to talk to you a little bit about our upcoming campaign. So what we had posted previously, that is the form for our upcoming drug policy campaign. We're going to officially be launching at our next webinar, which is going to occur a couple days before Overdose Awareness Day, which all of you that are on this call, you will be getting an invitation to that. So keep an eye out for that. And basically, by signing up, once you've signed up, you will get an email from me after you've signed up that will send a Calendly link So with that Calendly link, you'll be able to sign up a one-on-one with myself, and we can start going over like what your interests are with the campaign, what your interests are within drug policy. We can dive into, the policy landscape within your state, see what opportunities for change there are. Sorry, my daughter's climbing around like a spider monkey right now. And we can just kind of dive in, like, where do you fit in this? How can we drive change? As Lauren had mentioned previously, there are, it's going to take a significant amount of not only policy, like legislative policy changes, but also policy changes within our MOUD, our medication for opioid use disorder clinics and different things like that. So there's a lot that we can all do, and we're really looking forward to building this. If you signed up on the previous webinar or this webinar, you're kind of like an early adopter of the campaign. So I'm really looking forward to working with you and getting you involved and finding ways that we can all work together to ensure that we have safe communities and ensure that those individuals who are seeking treatment have access to treatment, and that, recreational users aren't getting caught up in the system, et cetera, all the different things that we can do. So now that I have talked about that, I really hope that you will put it in. You will receive an email tomorrow morning, and that will have that Calendly link in it for us. And you can look at my schedule, sign up a time, and we can chat and see what awesome work we can do together. So now I believe we will be switching over to the Q&A session. So we can take questions from the audience using that Q&A feature. You should see it down there at the bottom of the Zoom. What is that called? The little bar at the bottom. I don't know what it's called, but that bar, you should see the Q&A. And then if you can't find that, you can just go ahead and drop it in chat. And then once we go through those, if anybody wants to raise their hand or anything, we can do that. So I will pass it over to, I'm not sure if Lauren or John, or we can just start taking toolbar. That's the word. Toolbar is the word. I don't know why my brain would not think of that word. And then also I did want to see, congratulations, Kristen. That is so amazing that you just finished treatment. And I hope you're like feeling incredible and getting your energy back. That is so amazing. And I'm so happy for you.
And just to say, because I'm a doctor, hepatitis C is curable, completely curable, 2 to 3 months. That's it. Everyone, no one should live with hepatitis C. If you know anybody that has hepatitis C, have them see a doctor immediately. And I think the questions are anonymous, right? Nobody will see them except for the moderator. So feel free to ask anything.
Yes, and currently we don't have any questions.
I'm always willing to talk a little bit if that's okay.
Yeah, go for it.
Something came, the idea that there's only one way to recover just kind of burns me up. And sometimes the recovery community can be the hardest on itself. And I want to go back to what I said earlier in the webinar about the behaviors or the things that we should be concerned about, not what somebody is using. And whether somebody is on methadone or Suboxone or Vivitrol or abstinence or whatever it may be, medical marijuana, I don't care. What I care about is, are you working in a field that you're finding fulfillment in? Are you taking care of your family? Are you thriving in life? Are you taking care of your kids? These are the things that matter. And whether somebody is on methadone, Suboxone, Vivitrol, abstinence, what have you, doesn't matter. It's the behaviors. And if that medication is keeping someone stable to the point where they can maintain a job, take care of their kids, their family, what else could we ask for? And why would we try to harm them by telling them that they're not really doing a good job in their life when they really are?
I'm going to add to that, Dr. Cooke. I'm just going to throw in the actual definition of what recovery is. It is it's a process of change through which an individual improves their health and wellness, lives a self-directed life, and strives to reach their full potential. It says nothing in there about what substance you're on or anything like that. That is the actual SAMHSA definition of recovery. And so, if someone is improving their health and wellness, they're living a self-directed life, and they are striving to reach their full potential, they're in recovery.
Absolutely.
So Dr. Cooke, we've got, oh, I see them now. So first I want to get to Bonnie's question in the chat, which was, are you familiar with focused ultrasound treatment for opioid addiction?
If it's anything like, there's this device that you wear in your ear that I'm a little bit familiar with. I've not seen this particular verbiage used. Would be happy to talk with somebody about that, maybe offline or in another
Apparently
setting with that.
there's a link in the chat. And by the way, I think there's usually, oh, I don't know, maybe not. Sometimes there's a way to save the chat.
I'll just say this, and we've said it a couple of times, whatever works. And I'm not going to ever say, something doesn't work if it's working for an individual. So if it works for somebody, fantastic.
So we've got quite a few questions coming in. We'll start with this. What are your thoughts on legalizing medicinal marijuana as a replacement for opioids?
I wouldn't say a replacement. General, I'm in favor of decriminalization. Period. Whether it's marijuana or what have you, because I don't feel like that is actually solving our problem, and it's driving things underground and causing deaths and harms to our community. So I wouldn't necessarily say it's a great treatment for replacement on a large scale. Again, if it works for an individual, I'm not going to sit here and tell them that that's not the right thing for them. But I wouldn't say as a treatment modality for a large scale of population. I'm always one that's going to look at evidence-based practices, and we would need large studies, randomized control trial, peer-reviewed, that sort of thing. I think it's an option. If it works for somebody, great. There's also people who can't handle marijuana, and that gets out of control for their life, right? So, and by the way, I don't want to pit any groups against each other, but we don't talk about alcohol in these settings. But I really feel like they should be invited, into this conversation. In the recovery programs that I oversee, and I've admitted thousands of people to inpatient recovery centers. 60 to 70% of the people that we admit are from an alcohol-related disease, and more people die of alcohol-related deaths each year than all other drugs combined. So we don't talk about it because it's legal, yet it's still harming people. And I think we still need to acknowledge that even if it's legal, it can harm people. Even if we legalize marijuana, it may harm people. We still need to be involved in the care of that person, and making sure that they have access to health, wellness, and prosperity.
Fantastic. John B., someone thinks that it's great that you're engaging the youth in your campaign. What strategic approach are you using?
On that one, the main thing I used was youth. Like my daughter is a youth advocate, and I got her to really help me with that. I brought her in on the campaign, and I got her opinion. I asked her to reach out to some of her friends and really get some feedback from those people, from the youth, instead of just us old folks, as I get called all the time. Instead of just getting responses from adults and older people, it was, what do your friends think works? What are some things that they would like to see when it comes to prevention for someone in your age range? And really just, again, giving them a safe space to give feedback and really tell me what they want what they want out of this, what they would like to see happen for them going forward. And that was my main thing on that, was really reaching out to youth. So, they have a voice, and it needs to be heard, and really just respecting their wishes on that, was my biggest thing.
Great. So if you were to imagine a community resource that specifically addresses the issues that predispose people to addiction, what form might that take? Good
I
question,
always
right?
think of, yeah, I always think of yeah, absolutely. Gets right to the heart of it. I always think of the children, you know, it's easy to stigmatize a 54-year-old, person who's homeless and injecting heroin and fentanyl. But that person was a child born in our community, and we failed them in some way. So my question would be, how can we wrap each child that's born in our community in all the resources and support that they need to grow into a prosperous, healthy human life? I think we've hit on a lot of those features: basic human and safety needs, transportation need, humane housing, livable wage, access to community, access to a purpose-driven life with meaningful work. Those sorts of features was what I would want to see in a community. John?
Meeting basic needs and connections.
Yeah.
They say that the opposite of addiction is connection, and I believe that wholeheartedly. And really getting people connected with communities, with community resources, and making sure those are in place. That would be, beneficial, whether it's healthcare, childcare, transportation, housing, food, you know, clothing, all the above, just making sure that their basic human needs are met. And I think we would see a very positive outcome from that. I think if we can meet, a family's basic human needs, if someone is, homeless with addiction, has children, we have to take care of the whole family. And making sure that we're not separating families. If that person is the best fit for that child, if they're doing, if they're actually taking care of that child the best they can, and with proper resources, they would be doing a wonderful job if they had all the resources. So making sure that parents have those resources to help their child, and that's not always the situation. Not everyone needs children. Unfortunately, we know that's the case, but for those people that are really trying and are really good parents, I think, we need to make sure that they have those resources, and that's in every community. I think that we need to make sure that we do put family first in the whole aspect, from, making sure that we have healthcare for children, make sure that children have, healthy meals daily, transportation to appointments or to school or whatever that may be, but really making sure that we take care of those needs of the community. And I think we will see our communities flourish.
It's interesting. I was invited to Dubai for this big health summit, and on the panel that I was on, we were asked what can we do to make our communities healthier. Everybody was thinking of these big, grandiose programs, and all the panelists all agreed, just feed and shelter people. Give them healthy food and water, access to these basic human and safety needs. It actually is a lot simpler than what we sometimes make it out to be. We have to have the programs, we have to have all the treatment programs and all of that stuff in place, of course, but it wouldn't cost as much as we think to actually get into our communities and shift the paradigm of healthcare and harm reduction to these things that define what it is to be human. I always say it, not everything needs to be for sale. Some things should just be in our communities. We're okay with roads and education as being just part of our communities. We don't even have to worry about it, although we do have paid toll bridges and stuff that drive me crazy. But we could just take care of people. What would our communities look like if we just took care of each other?
So our last question for the evening is, for those supporting those living with chronic pain in healthcare, it's been challenging to bridge to informed and experienced support. Will part of the initiatives also focusing on centering margins for those living with chronic pain and/or disability?
I know that this population has been marginalized, and that really bothers me. I wrote an op-ed a few years back just addressing this in particular. I feel like we've abandoned people who live with chronic pain to our uh, to a place where they're alone. And when you're alone and suffering, then there's just a few steps away from ending a life. I really think we need to do a better job of letting people know that we're not going to abandon them just because they're living with chronic pain and use an opioid pain medication. There are options. There are all kinds of modalities and things that we can do. We should never abandon anyone, and to just say just going to cut you off and push you out the door because we don't know what to do with you is not okay. But Kelly Hahn's on here. I noticed earlier, and in Scott County, she and others championed this phrase. It's okay to not be okay. And we always need to make sure that everyone feels safe accessing care, because when they don't feel safe accessing care is when bad things happen. And we need to let people know it's okay to not be okay. It's okay to be experiencing chronic suffering in your life. And we're here to hear you and help you and do everything that we can um, to help you not experience suffering in your life.
Fantastic.
One thing
Uh,
I'll comment on that too really quickly is I've been having a lot of conversations about chronic pain patients and MOUD patients. And I know one thing that's being worked on or being talked a lot about is that like we're lacking a lot of work on like the forensic epidemiology side of things to track like people who are overdosing, like what's causing that. And we believe that a lot of what's causing it is people who are unstable, not necessarily overdosing because of the medication that they're prescribed. So that's one thing that I know that certain groups are like starting to push and work on. So forensic epidemiology, if you don't know, it would follow like the journey of the person, like throughout their medical and life journey. So that's one thing that like in Arizona, I'm working on the governor building a board that would look at that so that we can like actually have better statistics showing that like people aren't overdosing because they're shoveling all of their pills down. If they're chronic pain patients, they're overdosing, when say their chronic pain medication was taken and then they were to divert to something like fentanyl.
Right.
So yes, we are definitely thinking about chronic pain patients. I think a lot of you have been very irreparably harmed, and hopefully we can fix that.
Fantastic. One last question, and then we'll turn to Jay to close us out. Do you think direct-to-consumer advertising for pharmaceutical drugs contributes to people turning to drugs to answer all problems?
I think there's a lot of things that contribute to that. But I mean, the short answer is yes. We know for sure that that's part of what happened here with this opioid crisis, that it was direct to consumer advertisement and inappropriate advertisement to healthcare providers. So the short answer I would say is yes. As a physician, I always feel like part of my job is to really try to dig into the lifestyle issues that may be contributing to whatever their disease and their condition is. But we do have to treat it until maybe some of those other pieces are in place. So I don't want to say we shouldn't be treating people with medication, because we have to have those in place. But I don't like, personally, I don't like the direct to consumer advertising from that standpoint, although it does raise awareness. Maybe raising awareness to diseases to drive people into meet with their healthcare provider may be a better option than to say you need this pill to treat this thing. But yeah, I would in general agree with that sentiment.
Jay, are you in a place to take us away, or you want me to do the last slide?
She's a little crazy today. So I will make one comment, and then if you want, I'll let you take it away. One comment I just want to make very briefly is I will be sending out invitations to our next webinar. That is going to be when we announce the details of our large campaign that we're kind of teasing now. Because it is during Overdose Awareness Week, right before Overdose Awareness Day. There will be a form that I'll be sending out with the invitations. And we will have an option for people if you'd like to submit photos or stories of people that you've lost to the overdose crisis. We will be starting that meeting off with a vigil, and we would love to share photos or stories of your loved ones who have passed away from overdose.
Keeping their memory alive. Thank you. All right, so this is our last plug. We're asking you to join our campaign. Scan this QR code or click the link that you see in the chat. We appreciate, look, I know we've all got things to do, places to be. There are a million places you could have been tonight. You chose to spend your time with us, and we deeply, deeply appreciate it. We thank you for caring and sticking around for all of this. We hope that you'll sign up to join our last webinar, and we hope that you'll be part of our campaign and help us because we need all hands on deck. This is too big for any one group of people to tackle. So please join us, and thank you, thank you, thank you for your time, and good night.